Welcome to this educational presentation from Professor Mohammadi's teaching archives. Today, we will discuss a clinical situation where a seemingly common pediatric complaint, colic, may actually represent a time-sensitive neurological emergency. The focus is a 9-month-old infant with clustered abnormal movements, developmental regression and EEG findings consistent with infantile spasms, also known as West syndrome. The key message is simple but clinically important. Brief clustered spells, especially when associated with developmental change, should never be dismissed as benign without careful neurological evaluation. Next slide, please. Let us begin with the clinical vignette. A previously healthy 9-month-old girl presents with 3 weeks of brief, unusual spells. These episodes consist of sudden flexion of the trunk with bilateral extension of the arms. They occur in clusters or flurries, particularly after awakening. At first glance, brief spells in an infant may be misinterpreted as colic, reflux, startle, or non-specific discomfort. However, the most important clue is not only the movement itself, it is the change in the child's development and behaviour. The parents report that she is no longer smiling, babbling, or engaging normally. This developmental regression changes the clinical meaning of the events. We are no longer dealing with an isolated paroxysmal movement. We are dealing with a possible epileptic encephalopathy. Next slide, please. The red flags in this case should immediately challenge the initial diagnosis of colic. The events are repetitive, stereotyped, and clustered. They occur especially on awakening, which is a classic timing pattern for epileptic spasms. Most importantly, they are accompanied by developmental arrest or regression. Colic does not explain a child becoming distant, less socially engaged, and developmentally regressive. Reflux or benign startle may mimic some motor postures, but they do not explain the full syndrome. This is where clinical reasoning matters. We should avoid anchoring on the first label and instead ask what diagnosis accounts for the spells, the timing, and the developmental decline together. Next slide, please. Now we move from the history to the diagnostic clues. The EEG shows hypsarrhythmia, a chaotic high-amplitude background with multifocal spikes and sharp waves. During the clinical spasm, the ictal EEG shows a high-amplitude slow wave, followed by electrodecrement or voltage attenuation. These findings strongly support the diagnosis of infantile spasms. The skin examination is also essential. Multiple hypopigmented macules suggest tuberous sclerosis complex. This is not just an associated finding. It helps identify the etiology and influences treatment selection. The lesson here is that the diagnostic process requires integration. Clinical semiology, developmental trajectory, EEG pattern, and careful physical examination all converge toward the correct diagnosis. Next slide, please. The most likely diagnosis is infantile spasms, also known as West syndrome. This is not simply a seizure. It is a syndrome-level diagnosis and represents a developmental and epileptic encephalopathy. The classic triad includes epileptic spasms, hypsarrhythmia on EEG, and developmental regression or encephalopathy. Recognizing this triad is critical because the goal is not only to stop visible events. The goal is also to reduce the burden of epileptic encephalopathy and protect developmental outcome as much as possible. Once this diagnosis is suspected, the clinician should move quickly from recognition to treatment. Next slide, please. The best next step is urgent treatment while the etiologic evaluation proceeds in parallel. In this case, because tuberous sclerosis complex is suspected, vigabatrin should be started promptly. Treatment should not be delayed while waiting for prolonged additional testing if the clinical and EEG evidence already supports infantile spasms. At the same time, MRI and a full etiologic evaluation should be arranged. The child should also be assessed for systemic features of tuberous sclerosis complex. The key decision principle is that diagnosis and treatment should proceed together, not sequentially. In infantile spasms, delay matters. Next slide, please. This case also illustrates several common pitfalls. The first is anchoring, accepting the initial label of colic or reflux without reconsidering the diagnosis when new red flags appear. The second is delay, waiting for more events, more observation, or prolonged confirmation when the pattern is already strongly concerning. The third is using a non-specific anti-seizure medication instead of syndrome-directed therapy. The fourth is false reassurance, especially when parental concern is strong and developmental regression is present. In this vignette, the parents were right to worry. Their observation that the child was no longer behaving normally was one of the most important diagnostic clues. Next slide, please. The take-home message is practical and memorable. Clusters of brief, flexor or extensor spasms, especially around awakening, should raise immediate concern when they are accompanied by developmental regression. When hypsarrhythmia is present on EEG, this becomes a neurological emergency. Think infantile spasms. Treat early, evaluate the cause in parallel. Early recognition and prompt treatment can improve seizure control and may improve developmental outcomes. Next slide, please. Thank you for watching this presentation from Professor Mohammadi's Educational Archive.